Welcome to AETCM, the emergency medicine channel. A 73-year-old male presented to ER with complaints of multiple episodes of black-colored stool since one day. On initial 10-second assessment, airway was patent, no pooling of secretions. Breathing, respiratory rate was 18 per minute, saturation 98% on room air entry bilaterally equal. Coming to circulation, BP was 150/100 millimeters of mercury, pulse rate 79 per minute, all peripheral pulsations equally felt bilaterally. Coming to disability, GCS was 15/15, pupils equivalent reacting to light, and exposure, he was afebrile. Coming to sample history,
this patient, primary survey, when you checked, everything is normal. So, this is a patient with the history, melena. So, it is a upper GI bleed or lower GI bleed?
Upper GI bleed.
So, why do you call it as upper GI bleed?
Because it is altered blood. If it is lower GI bleed, it will be hematochezia, red blood in color. Since it is altered, it is most probably will be upper GI bleed.
Okay, so what is upper GI bleeding from?
The area of colon above the ligament of Treitz.
Okay, so when we are looking at the primary survey, what all things are you checking?
If there is hematemesis, airway should be checked for any aspiration or any blood in the mouth, foreign bodies.
Aspiration we will be checking in the breathing. So in the airway, what all things will
airway is secured or not, patent or not, due to any, if the patient is unconscious, then if there is, look for any blood in the mouth in airway.
So if, we need to look for blood in the mouth and sounds like?
Any gurgling sound.
Gurgling sounds. Okay. If at all it is there, what will you do?
We have to suction it out, position the patient.
How do you position?
Either a propped up position or in a recovery position for left lateral position for the.
If patient is conscious, you can put it in proper position. What is recovery position?
Recovery position is a left lateral position with the face should be flexed and face downwards. And then the left upper limb should be below the head, and the torso should be 90 degrees to the left back.
And when you are positioning like this, make sure that the head is also tilted down. Why?
Or else for easy oozing of secretions.
If head is down, then nothing will go up. So we don't want the patient to aspirate. So if the head is down, everything will flow downwards. It will not get aspirated into the lungs.
Then coming to breathing.
What else will you check in airway? So you will check for gurgling sounds. Any gurgling is there, you will be doing suctioning. If the patient is having active bleeding, you will put in a recovery position or proper position. Then
if the patient,
if there is any snoring,
we can put an nasopharyngeal airway or airway manuals we can try. If with an airway manuals the snoring is going, then we can try with nasopharyngeal airway.
What all manuals will you do?
Head tilt, chin lift or jaw thrust we can try. If snoring is relieving, then nasopharyngeal airway.
How will you measure the size of nasopharyngeal airway?
From the tip of the nose to the trachea.
Okay. Then
if the patient is unconscious and still having this hematemesis, we will need to secure the airway with intubation.
Okay. So, if you are planning for an intubation, what all things will you keep in mind?
Initially, we should not keep the position propped up before giving the sedatives and muscle relaxants, and ambu bagging should be done less
with caution because
it will promote nausea, vomiting, and aspiration
will promote gastric distension and vomiting. Okay.
And the suction should be younger section. If there is continuous hematemesis, we should use that suction assisted technique, intubation,
salad technique.
And if the view is less, we can use video laryngoscope.
Okay. So then breathing.
Look for desaturation, whether he have aspirated or not. We have to check for breath sounds to rule out aspiration, any wheeze or crabs.
So, respiratory rate also you'll have to check for it, because if the patient is a non-cirrhotic CLD patient and all, they might present in bradypnea. So that also should be checked. Circulation.
Circulation, BP, and pulse rate to classify the shock, whether there is hypotension or any tachycardia. And
So how will you classify?
Class 1 is there will be no hypotension, no tachycardia. Class 2 will be only tachycardia. Class 3 there will be both tachycardia and hypotension.
Okay. Any change in the monitoring of circulation if it is a CLD patient?
CLD patients normally will be in low BP.
They will be having a low blood pressure and
bradycardia.
why bradycardia?
Most probably they will be on beta blockers because for portal hypertension. So most probably they will be in bradycardia. If there is tachycardia on beta blocker, should be cautious.
Okay. Any other condition where patient will be bradycardia with hypotension? Any other patient presenting with upper GI bleed other than for CLD patients?
Obstructive jaundice.
Obstructive jaundice. No, patient has presented with upper GI bleed. Patient is having some background condition.
Any IC bleed?
That's not IC bleed. IC bleed patient will be having low heart rate with high blood pressure. Same upper GI bleed patient, if it is a CAD patient taking beta blockers, that also can reduce the heart rate. Heart rate will be shown as normal.
So in coming to circulation, at that time, if there is hypotension, if the patient is in shock, we should immediately put a 2 large IV bore cannula and call for a blood arrangement.
Take samples and call for blood arrangement. Okay. Disability?
Disability, look for GCS, whether he is in altered mental status either due to hepatic encephalopathy or due to hypotension.
Okay, so primary survey is done. So after primary survey, any adjuncts was used?
We had taken a VBG and CBC CRP, point of care, to look for hemoglobin.
First you need to tell that you put a cannula because it is a bleeder case. So you have put 2 large bore IV cannula. And what all things you are looking in a VBG?
VBG, we have to look for first the acid base, any metabolic acidosis or alkalosis, and then sodium, potassium, electrolytes.
This patient, what are you checking?
Hemoglobin we can.
Hemoglobin you can check.
Lactates.
Lactate you can check, and
potassium if there is ongoing bleeding, any hyperkalemia.
And metabolic status.
Metabolic status.
Okay.
And then in CBC CRP, the hemoglobin can be checked, and platelets.
Okay.
If there is thrombocytopenia or not.
Okay.
And then coming to history, a 73-year-old male who is asymptomatic cardiac status on acospirin, 75 milligram, presented to ER with complaints of multiple episodes of black colored stools, 6 to 7 episodes since one day. He had an episode of syncope associated with it, and no history of any hematemesis, any abdominal pain, hematochezia, constipation, jaundice, abdominal distension, or altered mental status. So he was taken to our ER. Then we had initially taken a VBG showing pH of 7.36 with a PCO2 of 43.7, hemoglobin 8.9, potassium 4.5, and lactate 2.5, create 1.3, bicarb 20.8, and point of care showing hemoglobin of 8.7. So he was a regular follow-up in our hospital. So 2 months back his hemoglobin was 13. And coming to examination, patient was conscious oriented. There was bilateral mild pitting pedal edema was there, and abdomen was not distended, no abdominal tenderness, no sinuses, and other systems were also within normal limit. So we had initially.
So what else will you check in this patient? It's not a known case of CLD or anything. So what else will you check in the patient's peripheries? So any features. So it is not a diagnosed case of CLD. So you will have to look for the other features of CLD. What other features?
Any jaundice.
Will all patients have jaundice? All CLD.
Any gynecomastia.
In the face.
Parotid enlargement.
Okay.
And
Neck, chest, spider navy, hand, any flaps, clubbing,
and then abdomen, any distension, any spinal distended veins, and any loss of pubic hairs,
And axillary hairs.
axillary hairs, any testicular atrophy, then pedal edema. There was mild pitting pedal edema.
And a PR examination also should be done. Okay.
For any hemorrhoids.
Hemorrhoids or
And
any
melena. So we had done initially with we had started on pan infusion since we are suspecting he is on ecospirin, so we suspected any gastric ulcer bleed. So we had
Only infusion was started?
No, 80 mg stat and then infusion, continuous infusion at 8 mg per hour was started.
Okay.
And we had done a UST abdomen.
Okay, so pan infusion, what is your idea behind starting pan infusion?
First one is if there is ulcer bleed, the acid will production will be reduced, and if it is varicose bleed, rebleeding will be prevented by pan infusion.
Okay. Anything else? Here usually in ulcer bleed only pan stat doses is required. Otherwise, what is our target as pH which we are planning to maintain by giving a pan infusion? We are trying to keep a pH of in the abdomen more than 6. Okay, so and why we are anyway this patient, if we are suspecting ulcer bleed only, we want that infusion to go on. So why infusion? To prevent rebleed, that is correct, whatever bleed it is. And other thing is that if the patient's abdomen is acidic, then that will prevent healing. So that's why we are putting, even though we don't know what is a pathology, we are putting as an infusion. But fixed stat doses also will help in this. Like if you are putting pan 40 mg BD, that also will help. So our target is to produce a alkaline environment, prevent acidosis so that the healing will happen. Okay.
Then we had done. We had initially kept the patient NPO and then started on pan infusion.
Pan infusion. How will you start pan infusion?
80 mg stat we had given, and then 8 mg per hour infusion.
So how will you dilute? How will you dilute? Anybody? How will you? If the staff doesn't know how to start pan infusion, how will you take an infusion? Anybody?
2 ampules.
2 ampules. Pan is coming as a vial. No, 1 vial is 40 mg. 1 vial is containing 10 ml, which is 40 mg. How much ampules you need to take? How much vials you need to take?
2 vials.
Okay, 2 vials. Then it will be how much ml?
20 ml, 80 mg.
20 ml, 80 mg. That will be, will it be diluted or not diluted? Diluted.
NS.
Which is the drug which we don't dilute in our ER? This we will dilute. Pan we will dilute. Any other medicines which we never dilute in ER? Labetalol. Okay, bicarbonate. Furosemide, Lasix, we won't be dilute. So this, now you have 20 ml, that is equal to 80 mg. That will be added with how much ml NS?
30 ml.
No, 20 plus 20. So we will be taking a 50 cc syringe. So 20 ml of pan, that is 80 mg, will be added with 20 ml of normal saline. So for total it will be 40 ml, which will be containing how much? 80 mg. So you are planning to start 8 mg per hour infusion. That means how much? 4 ml per hour infusion. Okay. Will you start octreotide for this patient?
No.
Why?
Because he is not a non-case of CLD and no prior any CLD reported, and also no prior esophageal varices also.
So why we are starting octreotide infusion for a CLD patient?
It may cause planktonic vasoconstriction. So it may cause a vasoconstriction of the esophageal varices. Thus, will prevent the bleed.
Okay. So we will be starting which is better, octreotide or terlipressin?
Both are same, but cost-wise, octreotide is less.
Then both are splanchnic vasoconstrictors, but terlipressin is having a side effect. What is that side effect? It will cause peripheral vasoconstriction also. Along with the portal vasoconstriction, peripheral vasoconstriction, and that will cause a CAD. That will precipitate a CAD, reduce perfusion to other organs. That can be there. So that's why we plan on starting octreotide infusion. Okay. How will you take, if so, this patient we didn't start octreotide infusion, how will you give octreotide?
Octreotide is 100 microgram stat and followed by 50 microgram per hour.
Infusion.
Infusion.
How will you start infusion?
We'll dilute in DNS.
How much octreotide will be taken? So how much you will be diluting in DNS? So how not DNS, dextrose. We need to dilute in dextrose current. So how much dextrose you are planning to take? 1 liter, 500 ml, 100 ml.
500 ml.
500 ml. So you have 500 ml. So in that you how much dozen is octreotide coming as a vial or an ampule? Pan is coming as a vial. Octreotide?
Vial.
No. It is coming as an ampule. It is kept in our refrigerator. So 1 ml will contain 100 microgram. It is an ampule of 1 ml. It is containing 100 microgram. And we will take 5 ampules. Okay, so total 5 ml. So it will be total 500 microgram. So 1 ml 100 microgram, 5 ml 500 microgram. That will be added with 500 ml of dextrose. So total how much is there? 500 microgram in 500 ml NS. So you are planning to start
50 microgram per hour.
Yeah, 50 microgram per hour. So how much ml per
50
hour?
ml per
50 ml per hour. Okay.
For this patient, we had also arranged for blood products. 4-pint PRBC was arranged, and USG abdomen and pelvis was done to roll out.
Will you transfuse blood for this patient?
The initial hemoglobin was 9.38 lab value, and since 2 months back he was having 13. So since there is 4 hemoglobin drop and also he is a asymptomatic cardiac status, we can transfuse
blood. You need to transfuse blood. Okay.
So USG abdomen pelvis was done.
And you are planning, you are suspecting an aspirin induced like an ulcer bleed only. So ulcer bleed is a continuous bleed. So if it is a varices bleed, it is a venous bleed. It will be an intermittent bleed only. But if you are suspecting ulcer bleed, it will be an active bleed. So in this condition, you will have to transfuse. Okay.
USG was showing no features of chronic liver disease. So we had initially informed gastromedicine team of our hospital, and we had kept the patient NPO. They had planned for OGDscopy.
Okay, so you have from ER, airway intervention, circulation interventions was not required. NPO was kept, pan infusion was started, octreotide was not required, blood also arranged and planning to transfuse. Any antibiotics?
Ceftriaxone.
Why ceftriaxone you selected?
Upper GA bleed, we usually either fluoroquinolones or ceftriaxone will start, and according to antibiogram of the hospital protocol, we can transfuse. So third generation cephalosporin is good enough. Okay, so if you can start ceftriaxone. Why you are starting ceftriaxone? To prevent any GA infection. Already bleeding is the blood is the good culture media.
That's why. Okay. So if it is a CLD patient, will you start something else? So this patient is not a CLD patient, that's why you started ceftriaxone. If this patient was a CLD patient, will you be altering your antibiotic of choice?
Ceftriaxone, sulbactam.
Okay, can be added. So why?
That's the antibiogram of our incident.
What is the other complication of a CLD patient? SBP. So you need to prevent an infection in the abdomen and in the ascitic fluid. So if the CLD patient is having ascites also, if the patient doesn't have ascites, you can start ceftriaxone. If the CLD patient is having ascites, then you will have to start on cefoperazone, sulbactam or a higher antibiotic. Okay.
Rifaximin also we can start according to the
for prophylaxis. Okay.
So OGD was done by the gastromedicine team, and the impression was no fresh or altered blood noted till D2. So they withheld the ecospirin and was monitoring for the hemoglobin, but there was a hemoglobin drop. From 9.3 it was 8.5 and it was 7.3.
Okay.
So they planned for a colonoscopy, and colonoscopy was showing a small internal hemorrhoids with no red color sign, colonic diverticulosis, terminal ileal erosions, and no fresh or altered blood, melanic stools noted till terminal ileum. So they have diagnosed as the upper GI bleed, probably secondary to colonic diverticulosis.
What is red color sign?
There is possibility for bleeding.
Yeah, that means something a red point. That can be because of a bleeding spot which has healed or a spot which is going to bleed. Okay. So what will be done by them if there is a red color sign?
Banding.
Banding or some procedure has to be done. So right now it is not bleeding doesn't mean that it is not a bleed. So red color sign should be treated. Okay.
So we had transfused 2 pint PRBC, and further they were.
So they got a diagnosis from the colonoscopy. As a colonoscopic, what
colonic
diverticulate. Okay. So what if the colonoscopy also was negative? What else will be planned? CT angio can be done. So because there is no point in doing a capsule endoscopy because anyway they know there is a GA bleed. So in tertiary care centers we can do a GA bleed protocol, CT angio, to look for any oozing. That also mostly it will pick up, or we can plan on doing a endoscopy. That is to visualize the small intestine. Okay, so okay.
So then they restarted the ecospirin and they monitored the hemoglobin. There was no drop for the hemoglobin, so they discharged the patient.
Okay. You want to tell about anything else?
Scoring system. In upper GI bleed, we have mainly three scoring system. That is Glasgow Blatchford score, Rockall score, and AIM 65. Glasgow Blatchford score it predicts the need for immediate intervention. It contains blood urea nitrogen, hemoglobin, BP, heart rate, melena and syncope at presentation, any hepatic disease at presentation, any cardiac failure at the presentation. If it is more than, the score is more than 6, 50% risk of needing intervention is there. Then in Rockall, there is a risk for further.
Nothing like that. If GB score is more than 0 itself means patient should be admitted.
Then Rockall score, it risk for further bleeding or death. It includes age, shock, other major comorbidities, and other diagnoses like Mallory Weiss, non-malignant GI diagnosis, and malignancy and recent hemorrhage. And AIM 65 is albumin less than 3, INR more than 1.5, any altered mental status, and systolic BP less than 90, and age more than 65. In AIM 65, our patient was having only age more than 65 was the only condition we had.
Okay, so this patient, the major treatment is from the gastroenterology part, our part only medication. So suppose you don't have a gastroenterologist in your center, what will you do?
We can, if there is major hemoglobin drop or hypotension, we'll have to.
No, patient is having active hematemesis.
Medically we can manage, and then
medically not getting managed.
Any that we can give a Sangstaken tube. To prevent the
so before putting that tube, what you will have to do? So you are planning to put a SB tube or a Sangstaker Blatchford tube. Okay, before putting that tube, what should be done? Because it is a very big tube. So what can sedate? If you sedate, what will happen? Aspirate. So you need to prevent aspiration. So for that, what will you do?
Prokinetic agents.
Intubate the patient. So if the patient is having active hematemesis and if you are planning to put this SB tube, then you will have to intubate the patient. Then how will you put the tube? So what is that tube? How is it different from a Ryle's tube?
There are two balloons which can be inflated. One will be at the G junction. And other in the esophagus, it will be there. So
one is in the stomach and one is in the esophagus.
So One will be first the balloon in the stomach will not pull the means prevent the tube to be getting out, and then the esophageal balloon will compress the varices.
So what we will do is first we will insert this tube. So this tube is having two balloons. So there's three openings for the tube to outside. So one is to inflate the stomach, one is to inflate the esophagus, and one is for suctioning from the stomach. So we will first insert the tube, and how will you inflate the tube? With saline or air? How will you inflate all the tubes? Except for Foley's, everything will be inflated with air. So here we will have to inflate it with air. So first we will inflate the gastric opening with 50 ml of air. Then after that we will have to take an X-ray, or we will try pulling it out. Better to take an X-ray. We don't want other injuries to happen inside. So take an X-ray and confirm the position of the tube. After that you inflate 200 more. So total there will be 250 ml of air in the gastric balloon, and how much then we will have to inflate the esophageal balloon should be inflated so that the pressures of the esophageal pressure will be between 30 to 45. So that much you will have to inflate, and you can shift the patient after stabilizing hemodynamics. You can plan on shifting. Any other tubes other than SB tube? We have the Minnesota tube. Minnesota tube is same as SB tube, but the only difference is that instead of 250 ml of air that is being put into the stomach, we will be putting 500 ml of air into the gastric balloon. And another thing is that Minnesota tube is also having an extra port for suctioning the esophagus. Here we can suction only the stomach. So we have an extra port for doing the esophagus. And one more tube is there. What is that tube? One Linton's tube is also there. That is only having a gastric balloon, okay, and gastric suction. So how much time? So just imagine you have put a tube like this. What is the maximum time to which you can put this tube? An SB tube or a Minnesota tube, a tube like that.
12 hours.
Only up to 8 hours. After 8 hours, what will happen? No, if you are putting prolonged time, what will happen?
Pressure will cause.
Pressure will cause erosion over the gastric or the esophageal walls. Okay, so within that time, so just only, if there is no gastroenterologist, that doesn't mean that this tube will help. So we'll have to put this tube, and we'll have to transport the patient to somewhere else. Okay.